The Hondius cluster is closed, and the blunt fact, after everything that happened, is this. There's still no approved treatment for Andes-virus. None. If you're just joining, quick reset. The MV Hondius outbreak started as a cluster of severe respiratory illness on a Dutch-flagged expedition ship, later confirmed as Andes Hantavirus. 13 illnesses, 3 deaths, passengers and crew traced across multiple countries. Quarantines and monitoring have wound down after negative tests, and the U.S. contacts finished their monitoring with 0 American cases.
This is Hantavirus Watch. Today we stop watching the perimeter and step inside it. What an ICU can actually do for an Andes-virus patient, who the Air Force unit in Omaha was actually caring for, and why a peer-reviewed paper helps explain why the cross-border tracing felt so ragged. We're staying on MV Hondius Andes-virus outbreak. Follow the show and you won't miss what comes next.
From European Commission.
The Commission was notified on 2nd May 2026 of a cluster of severe respiratory illness on MV Hondius, a Dutch-flagged wildlife expedition ship with passengers and crew from 23 countries, including 9 EU/EEA countries. The virus has been identified as Andes Hantavirus, the only hantavirus that can be transmitted person to person, typically requiring close, prolonged contact.
The European Commission's outbreak page finally puts hard numbers on what we've been circling. Notified May 2nd, MV Hondius. Andes Hantavirus confirmed. Passengers and crew from 23 countries, 9 of them EU/EEA. And Brussels is calling the risk to the EU/EEA population very low.
Very low for the population. Fine. But the Commission is finally spelling out the geography we've been staring at. 23 countries on one expedition ship, 9 of them European.
Right, and the notice matters because it's the official EU register entry. We don't have to infer it anymore. The Commission was looped in on May 2nd, and the strain ID matches ECDC's Andes page exactly.
23 countries means how many health ministries, though? If you were on that ship, very low risk doesn't tell you who's actually calling you back. So when a severe Andes virus patient ends up in the ICU, are doctors actually attacking the virus? Or are they mostly running life support and hoping the immune system wins?
Honestly, mostly the latter. Medicine just doesn't have an Andes-specific drug to reach for right now. A review published this month in NPJ Viruses says there are currently no approved vaccines or therapeutics specifically for Andes virus. Full stop. So clinicians are doing aggressive supportive care, carefully managing fluids, supporting oxygen levels, and in the worst cases, using extracorporeal membrane oxygenation, ECMO, to do the work of the lungs while the body mounts its own response. The Merck manual puts the case fatality rate for hantavirus pulmonary syndrome at 35 to 50% even with that level of care, which tells you how dangerous the cardiopulmonary phase is. PAHO's new 2026 interim regional guidance for suspected and confirmed Andes virus cases is basically the clinical playbook for the hemisphere right now. It emphasizes early hospitalization and intensive monitoring because the slide from flu-like symptoms to circulatory collapse can be very fast. There are antiviral candidates being studied in the lab, including some repurposed drugs. But as the AP reported this month from Santiago, none have cleared the bar for human clinical use yet.
If nothing's proven to kill the virus, what should someone do the moment they think they were exposed? Is there any window to act before it gets bad?
The CDC is explicit on this. If you think you had contact with someone who has Andes virus and you have any symptoms at all, contact a medical professional immediately. Don't wait to see if it passes. That window matters because early supportive care before the lungs and circulation crash is the main lever clinicians have right now. With no antiviral on the shelf, getting escalated to intensive care quickly is essentially the treatment. From Jeffrey Robb at University of Nebraska Medical Center Newsroom.
When the charter flight carrying Americans exposed to a rare and potentially deadly hantavirus landed in Omaha, Nebraska on May 11, 2026, Air Force medical professionals from the Air Force Research Laboratory's 711th Human Performance Wing were already in place supporting the response. Assigned to the U.S. Air Force School of Aerospace Medicine's Center for Sustainment of Trauma and Readiness Skills, or CSTARS Omaha, the team partnered with UNMC and Nebraska Medicine to care for and monitor passengers exposed to the Andes-virus, a strain of Hantavirus found in South America.
Here's the detail we didn't have before. When that charter from the Canary Islands landed in Omaha on May 11th, Air Force medical professionals from CSTARS Omaha were already in place. 17 U.S. citizens and 1 UK resident, all off the Hondius.
Already in place, so the response was set before the plane hit Omaha. They were waiting in the biocontainment unit for that charter to land.
Correct. CSTARS is the Air Force Trauma Readiness Unit embedded right at UNMC. That's why they could partner with Nebraska Medicine to monitor Andes-exposed passengers on basically no notice.
And look at that photo, full PPE, one of them mopping the floor around a simulated patient. That's the protocol the Air Force trains to. The question I keep coming back to, did the Hondius crew who cleaned cabins and moved sick passengers get anything close to that, or were they working barehanded?
That image is a 2024 training shot, to be precise. But the readiness in it is the point. And it tells me the U.S. posture here ran deeper than a CDC Level 3 framing would suggest. Civilian biocontainment plus an Air Force medical wing is a dual-track response.
Which is reassuring on the surface. Except remember what we just heard in the step back. There's nothing approved to give these patients. So the military's there, the experts are there, and the toolkit is still oxygen and circulation support.
Here's Dotsi Bobortsi W, Pi M at PLOS Global Public Health.
We are more globally connected than ever before, and our destinies, regardless of who we are and where we happen to live, are inextricably intertwined. Climate change, conflicts, and disease outbreaks are powerful reminders of this simple fact. The movement of people, goods, and services across borders has delivered enormous economic and social benefits, but it also accelerates the spread of infectious diseases.
This is the context underneath a lot of what we've covered this week. Dotse Bobortsi and Pi in PLOS Global Public Health, published on the 27th, arguing that retreating multilateralism amplifies outbreak risk, and in this case, it maps onto something concrete. This Hondius cluster needed contact tracing across the US, the Netherlands, and Argentina. When the machinery for sharing patient data between countries degrades, that coordination gets harder. That's their argument, and they're making it in peer review.
Yeah, and honestly, this is the paper that explains why I couldn't get a straight answer on synchronized quarantine clocks all week. A fraying data sharing framework between 3 governments doesn't stay in the conference room world. It shows up as a fuzzy cross-border picture. One thing listeners should know, Pi discloses he advises the WHO and the Gates Foundation. Doesn't sink the argument, but the guy warning that multilateralism is retreating is also embedded in the multilateral institutions.
If you follow Hantavirus Watch for clear outbreak updates, try Ebola Watch, a daily briefing on Ebola in DRC and Uganda, with case counts, border tracing, WHO vaccine news, and traveler guidance. Find it wherever you listen to podcasts. You'll find links to every story from today's briefing in the show notes. So if something caught your ear, you can dig in a little further there. That's Hantavirus Watch for today. This is a Lantern podcast.